Good evening. I'm Dr. Jim Andrews, and I welcome you to the fourth edition of the American Sports Medicine Institute's Sports Medicine Update webinar series. Tonight, we're proud to present four of the non-operative sports medicine specialists who work for the Andrea Sports Medicine Orthopedic Center in Birmingham, and they will speak on overuse injuries in sports. Before we introduce tonight's faculty, let's cover a few housekeeping points. We will address questions during the panel discussion at the end of the presentations. Please submit questions for the panel using the question and answer button at the bottom of your Zoom screen. Because of the upcoming holiday weekend, it may take a little longer than normal to receive your CME or CEU certificate for tonight's webinar. If you haven't received it by Monday, please email Caroline May at caroline@andreasportsmedicine.org. Participants other than MDs and ATCs will receive a certificate of attendance that can be presented to your profession's board to receive credit for tonight's session. You'll have to turn that in to them. When you receive your certificate by email, there will also be a link to SurveyMonkey questionnaire asking about your educational experience tonight. Please be kind. Your comments will help us determine whether or not this activity has met your educational needs. They will also provide a basis for future improvements in our educational activities. So thanks in advance for taking a few minutes to provide some feedback on tonight's webinar. The only faculty member that has indicated that they have an affiliation or financial interest that may be perceived as posing a potential conflict of interest is me, Dr. Jim Andrews. I serve as president and board member of the Andrews Research and Education Foundation in Gulf Breeze, Florida, as well as the American Sports Medicine Institute here in Birmingham. These relationships have been mitigated by ASMI's education department and are not relative to tonight's educational activity. The remaining faculty and activity planners have indicated that they do not have any affiliation or financial interest that may be perceived as posing a potential conflict of interest. Now let's meet our faculty members. First up is Dr. J. Aman Vada. Jay received his medical degree from the American University of Antigua College of Medicine. He then completed his residency in Bogalusa, Louisiana, that is in the Rural Family Medicine Residency. While in residency, Dr. Amar Vada was the founder of the Royal Bogalusa Sports Medicine Institute, a program which provided free sports medicine physicals and sideline sports coverage to rural Louisiana student athletes. He was a 2017 graduate of our ASMI Primary Care Sports Medicine Fellowship Program. And upon graduating, Jay was hired by Andrews Sports Medicine here, and he serves as team physician for Jack State University and Tuskegee University, as well as multiple Birmingham area high school. Jay's topic will be lower extremity injuries and stress fractures. Take it away, Jay.
Thank you, Dr. Andrews, for moderating this session of Sports Medicine Update. Dr. J. Muravadia, thank you for everyone joining us. Our topic tonight, at least one of our topics tonight, will be stress fractures of the lower extremity. All right, so stress fractures. There's two different types. There's fatigue fractures and insufficiency fractures. The fatigue fracture is more of an abnormal stress on a normal bone, and an insufficiency fracture is more of a normal stress on an abnormal bone. Fatigue fractures usually happen with a new or different type of activity or strenuous or repetitive overuse activity. Insufficiency fractures are most likely seen in postmenopausal or amenorrheic women in younger and older ages. So incidence of stress fractures, the general athletic population is less than 1%. Runners can be as high as 20%. They mainly happen in the lower extremity, and 95% of them happen in lower extremities, and half of those are the most common site is the tibia. As you can see here, body sites, according to epidemiological studies, the lower leg, 40.3%, foot, 34.9%. Like I said, 95% of most of these stress factors happen in the lower extremity. Most common in the lower leg are girls track and boys track, as well as cross country, boys and cross country and girls. And you can see the most common site in the foot, mainly in lacrosse, basketball, cheerleading, girls volleyball, soccer, high impact sports. Risk factors: females are more likely to have stress factors than men due to the female athlete triad. They have low estrogen levels. 49% incidence rate of stress fractures of less than 5 periods per year. Male distance runners have decreased testosterone levels that can increase risk of stress fractures as well. Whites are more commonly involved having stress fractures. So fitness level, why do we have different risks? Why do men and women have stress fractures? Most commonly, biomechanics can cause forced transition due to muscle fatigue or disuse. There's anatomic factors. There's bony issues such as osteopenia or osteoporosis, as well as rheumatoid arthritis. There's nutritional deficiencies that can cause stress fractures. There's also extrinsic variables such as different footwear, sneakers, surfaces that people run on or play on. Different stress fractures can happen in different body parts, such as baseball and tennis, which are primarily upper body sports. Humerus is most commonly involved. Ballet can cause lumbar, femur, and metatarsal stress fractures. Dr. Ortega will talk about lumbar stress fractures later in this session. Sprinters can deal with navicular stress fractures. Long distance runners can deal with pelvic and femoral neck fractures. Rowers and golfers can deal with spine, foot, and pelvis. Hurdlers can have rib stress fractures, and other sports such as bowling, running can deal with sacrum and pelvic stress fractures. So how do they happen? It's an insidious onset of pain that usually happens over 2 or 3 weeks. It's aggravated by activity and relieved by rest. In clinic, it's more of a clinical diagnosis, and if needed, we get an MRI, which we'll talk about in a few minutes. Differential diagnoses of patients that come in for a stress fracture. It can be a stress reaction, which is a pre-stress fracture, periostitis, exertional compartment syndrome, infection, which is less likely, nerve entrapment. It could be a muscle strain. It could also be a neoplastic type of tumor. So x-rays, they are initially negative. If you see something on x-ray that show up later, they typically are related to either an old stress fracture that is healed or a subacute to chronic stress fracture that is on x-ray. Typically, we see these on MRI. If you see them at 2 to 12 weeks, you usually see a periosteal reaction along with endosteal thickening and radiolucent cortical lines on the surfaces of the metatarsals or long bones of the body. Gold standard is a bone scan. Up until a few years ago, we used to do bone scans often. Now that I believe that has changed to an MRI. Sensitive but low specificity. There's also 50% false positive rate in a bone scan, and it's usually caught within the first 48 to 72 hours. And if it's an acute stress fracture, you can see uptake, as you can see here on the right side. You can see focal uptake in the bone here. If you're trying to monitor healing, bone scans are not effective way of diagnosing them or treating them. An MRI, you get typically an earlier diagnosis and earlier treatment plan. As you can see here on the right side, you can see a proximal tibial stress fracture in a young adolescent athlete here. High sensitivity and specificity. You typically get a high signal on T2 imaging and a low signal on T1 imaging. A stress response or a stress reaction, you don't see a fracture line. MRIs do help in grading stress fractures. Is it grade 1, grade 2, grade 3? Is it something that needs surgery? It is more expensive than a bone scan, but is a lot more sensitive and specific in terms of treating it and coming up with a game plan on how to get your athlete or patient back quicker. CT is also another way of treating a stress fracture. You can see endosteal or periosteal new bone, soft tissue edema if there's swelling in the bone, Tarsal-navicular stress fractures are not typically well seen on MRI. And then if you have a longitudinal tibial stress fracture, it's best seen on CT scan. So there are low-risk stress fractures as well as high-risk stress fractures. 6 weeks from an inciting activity is usually a low-risk stress fracture. If they're having trouble weight bearing, you typically put them on crutches, plus or minus NSAIDs or analgesics. Typically, you want to rest them or prevent them from any type of further worsening of the stress fracture. You can do cross training such as pool, biking, stairmaster, rowing, as long as they're not dealing with any upper body extremity injury. And then when they get pain-free 6 weeks later, you get to a gradual return to impact and running. High-risk stress fractures such as femoral neck, patellar, tibial, medial-malleolar, talus, navicular, and fifth metatarsal stress fractures typically are well treated with a surgical consult. Those are treated operatively. They can coincide with displaced operative stress fractures, fractures, chronic changes, and then high performance athletes, if they're been dealing with for a while, you may consider early intervention with surgery. Femoral stress fractures, which we'll get into next, are most commonly seen in distance runners, groin, thigh, or knee pain. Usually they come in with pain with an internally rotated hip and an antalgic gait. They can be seen in the neck of the femur as well as the shaft of the femur. Femoral conda are rare, but can happen from overuse in the knee. So they're compression-sided, femoral neck compression-sided stress fractures happen in younger, healthier patients, usually in a transverse fashion. They're usually stable. Most of these compression-sided stress fractures versus tension-sided stress fractures are treated non-operatively. As you can see here on the right side, you can start to see some edema here, as well as on the T1 imaging. On the left side, you can see some femoral neck changes on MRI imaging. Here's a tension-sided neck fracture. You can see here, this is an unstable fracture that would need to be surgically treated. And it's more of a displaced fracture. Again, you can see more of a tension-sided femoral neck fracture, which is more toward the superior aspect of that femoral neck. When you see that, it's an unstable fracture and can lead to the picture on the right side, a collapse that will need to be immediately treated. Typically, these are how they are treated, with screw fixation. Tibial stress fracture is the most common site, especially in the lower extremity. 20 to 75% of stress fractures, depending on the patient population, they are bilateral in 15% of patients. Most of them are transverse, meaning side to side. They could occur anywhere in the tibial shaft. Most likely commonly seen in the posterior medial aspect of the tibial shaft, which is where the compression happens from running in sports. So proximal tibial stress fractures happen in volleyball, basketball, military, and adolescents most commonly. Middle or ballet, mid to distal third or baseball and runners and cross-country athletes, and uncommonly less seen are longitudinal stress fractures. So the middle third anterior cortex is the most common. You can see them here on the picture or image on the right side. They develop a quote-unquote dreaded black line. Typically, if you see a dreaded black line on X-ray, that usually means you will end up with a intramedullary rod down that tibia to treat it prophylactically before it snaps in half, as you've seen in a few athletes. There it is again, a dreaded black line on the tibia. You can see that here on the right side of the image. Another commonly seen stress fracture in the lower extremity is the medial malleolus, which is still part of the tibia, distally speaking. A third of these end up with third of runners that have stress fractures in the lower extremity happen in the medial malleolus. Treatment for them, incomplete fracture or negative X-ray. Typically, you see them get an MRI. If they have it, you try casting or bracing. May take 4 to 5 months to recover. If they have, if you want to get them back sooner or quicker, sometimes you consider surgery. If they have a complete stress fracture that's all the way through, or a displaced fracture, or something that's taking longer than 8 weeks to heal, you would consider screw fixation with surgery. Distal fibular stress fractures, which is what we call a runner's fracture. Actually had one of these at Jacksonville State a few weeks ago in a quarterback that went to running too quickly. You typically want to get an MRI on them on the front end. We are treating this non-operatively, typically on the front end. Takes 6 to 8 weeks to heal. If they still have symptoms, then you may consider surgical intervention. You also want to check vitamin D levels and calcium levels, ensure they are within normal limits. And if they're not, you want to supplement them. Calcaneal stress fractures, runners, walker, aerobic athletes. You can see them in young and as well as older active sports athletes and weekend warriors. They have diffuse heel pain with walking or weight bearing. They are usually come in with crutches and unable to weight bear. They can be confused for occasionally for plantar fasciitis. So sometimes you want to get an early MRI if you're concerned about a stress fracture. Typically, patients with plantar fasciitis do not come in with crutches. So you restrict the activity or put them in a boot or a cast for 4 to 6 weeks, and it should heal non-operatively just fine. Metatarsals, middle and distal shaft of the second, third, and fourth metatarsals are the most commonly seen stress fractures. As you can see here on the right image, second metatarsal's got significant amount of callus. If you see that, it's either old or newly formed recently. Oblique, transverse compression, and longitudinal are the type of stress fractures that runners, military, and ballet deal with. Typically, they're treated with non-operatively with weight bearing as tolerated in a boot or a cast for 4 to 6 weeks. Fifth metatarsal stress fracture is known as a dancer's fracture or a Jones fracture. Typically treated, if it's a stress fracture, typically treated operatively. We see this a lot in high-level athletes such as basketball and football. Avulsion injuries of the fifth metatarsal can also happen. We typically put them in a boot and get them started on some physical therapy if it's a small avulsion fracture. If they have a Jones fracture, you can try to treat it non-operatively with a weight-bearing boot for 6 weeks. If they still have pain, you can either get a CT scan or an MRI to see where the healing rate is happening. Typically, high impact athletes and elite athletes typically need to have this treated surgically. As you can see here, operative treatment is with a screw plus or minus a bone graft, and then they get immediate weight bearing in the boot or cast. It typically takes 8 to 9 weeks to heal. This is what it looks like. On the left side of the screen, you'll see a completed stress fracture and then the pin fixation with ORIF in the middle picture. And then the right picture, you can see the significant healing that has happened due to early fixation of that fracture. Recurrence rates, you have to keep in mind that these can recur as well. You have to keep in mind that if they've had surgery before and they start having pain, is it the hardware or is it the bone? That's where early imaging and early intervention can help get them back to speed. Summary, prevention is important. Avoid improper training techniques. Make sure they're cross-training. Most stress fractures can be treated with rest. Certain high-risk stress fractures can be treated more aggressively with treatment such as casting and surgery. And intense inside femoral neck fractures are best treated with surgery. These are things to ensure that they are treated appropriately, quickly. Thank you for your time today.
Hi, I'm Emily Casey. I'm one of the non-surgical sports medicine at Andrews Sports Medicine in Birmingham. And tonight we are going to be talking about the female athlete triad and relative energy deficiency syndrome in sports. I don't have anything to disclose. A little bit about the female athlete. The female athlete triad, of course, encompasses disordered eating with energy availability issues, amenorrhea, osteoporosis. We'll also talk about treatment and prevention. A little bit of history. In 1896, Olympics were male only. In 1938, the first woman played in the men's PGA Tour. In 1944, women were temporarily playing baseball in baseball leagues while men were at war. And in 1984, the first woman competed in an Olympic marathon. We all know about Title IX, the Educational Amendment Act of 1972. And with this Title IX, we've had a dramatic increase in girls' participation in sports. The National Federation of State High School Association reports that of the 7.5 million athletes who participated back in 2008, 2009, 41% of those were girls. In 1972, only 7% were female. And between 1972 and 2011, the number of girls competing in high school sports went from under 295,000 to nearly 3.2 million and is growing today. Benefits of exercise for females and all athletes. This can certainly decrease the risk of breast and endometrial and colon cancers, diabetes, hypertension, cardiovascular disease. It can improve self-esteem, body image, decrease your BMI, and increase bone density. In 1992, the American College of Sports Medicine identified an association of disordered eating, amenorrhea, and osteoporosis in athletes who participated in sports that emphasized a lean physique, entitled this female athlete triad. In 1997, they came out with their first position stand, and in 2007, they updated this to include low energy availability with or without eating disorders, menstrual dysfunction, and low bone mineral density. Prevalence of disordered eating among high school and college athletes ranges from 15 to 62% compared to 13 to 20% in the general population. Majority of female athletes do not always have all three components. Rather, there's a continuum from health to disease, or they may have one component. As far as REDS, the triad was felt to exclude half the population. So the REDS clinical model, first described by the International Olympic Committee in 2014, now incorporates females and males. It describes multi-system effects, which are not just limited to these menstrual fractures and bone health, but both the triad and REDS understand that the underlying issue is low energy availability. The value of energy availability required to maintain resting metabolic rate is at least 45 kilocalories per kilogram of fat-free mass. The energy availability is not an absolute threshold applicable to everyone, but it is a guide. A little bit more about the relative energy deficiency in sports, looking at male cyclists. So male cyclists are at risk for this for a few reasons. Road cycling is a non-impact exercise, so there's no osteogenic stimulation, and it also encourages low body weight. So cyclists may not show pain with weight bearing due to their sport. They may first present with a serious fracture of a vertebral fracture because of low bone mineral density. REDS in the military has also been looked at. Military personnel are exposed to energy deficits, high training activities, and so these energy deficits can result in several components of the triad or REDS, mostly disturbances in endocrine and metabolic function, bone turnover, immune function, GI health, mood, physical, and cognitive performance. And we definitely need to look at more studies that look at the long-term and short effects of these energy deficiencies and how these athletes and military recover. As far as the female athlete triad, elite athletes, how it presents, about 4% of elite athletes will present with three components of the triad. And high school female athletes, you may have 78% of these high school athletes present with one component, and 1 to 2.5% may present with all three components. Energy availability, the actual definition is energy intake minus energy expenditure. So the energy remaining after exercise, that's what's left for your normal body function. When you have intentional increase in caloric expenditure or decrease in caloric intake, that causes low energy availability, and it can certainly manifest as disordered eating. Disordered eating behaviors include restricting eating, laxatives, skipping meals, fasting, and binge eating. We did talk about to maintain a positive energy balance, you need to at least have 45 kilocalories per kilogram of lean body mass. When you start going below 30 kilocalories, then you start having compromises in physiologic processes such as amenorrhea, infertility, osteoporosis, and stress fractures. Looking at disordered eating a little bit more, there is anorexia, bulimia, binge eating. These are 10 times more prevalent in women than men, and about 50% will have a relapse. And again, these are more common in sports that emphasize leanness, aesthetics, weight class or endurance, such as gymnastics, ballet, cheerleading, and running. Some of the risk factors or personality traits to look for would include perfectionism, compulsiveness, athletes with abnormal eating habits, high pressures from coaches and parents, if you have a family history of eating disorder or abuse, or depression. Other signs and symptoms to look for as far as eating disorders: when your athlete avoids eating in social settings, frequent trips to the bathroom, continued weight loss and dieting, again, stress fractures, the Russell sign or the calluses over the knuckles, dental issues, amenorrhea, bradycardia, hypotension, hypothermia, anxiety, and depression. How do we diagnose these things? Well, we need to start with our pre-participation exams, which we do in high school, college, and our elite athletes. You need to ask about their weight and diet history, stress fractures, menstrual cycles, psychosocial stressors. If you see athletes that present with any one risk or component, you should definitely question them more and start paying attention to that athlete. As far as disordered eating and the prognosis, Steinhausen conducted an analysis of multiple outcome studies looking at anorexia and bulimia, and again, the prognosis of these type of patients. They found that there was recovery in about 46% of patients with anorexia and 45% with bulimia. There was improvement in their situation with 33% of anorexia and 27% bulimic patients, and of course, a chronic course in about 20% of anorexic patients and 23% of bulimic patients. These type of things can sometimes be a lifelong battle. Mentioning menstrual cycles, we know our normal cycle is dependent on intact hormones from the hypothalamus and pituitary. You have that follicular phase, LH surge, and luteal phase. As far as menstrual dysfunction, which is menstrual irregularities, these type of things occur in athletes at an estimated 69% in athletes compared to 2.5% in the general population. Some definitions: primary amenorrhea is the delay of menarche by age of 15 in the presence of normal secondary sexual development. Secondary amenorrhea is the cessation of menstruation for 3 consecutive months in an adolescent who has already started menstruating. And those common things could be pregnancy, polycystic ovarian syndrome, or functional hypothalamic amenorrhea, which we are going to talk about. In the absence of menses due to suppression of the hypothalamic pituitary ovarian axis without any other identifiable anatomical or organic cause, this is functional hypothalamic amenorrhea, and this is what is in the setting of this inadequate energy availability. It can be stress related, weight loss, or exercise related, and it is more common in athletes, again, in sports that emphasize weight and shape. With this, there's an altered gonadotropin releasing hormone pulse, which then disrupts the LH pulse from the pituitary and gonadal steroid release from the ovaries. This reflects in a deficiency of estrogen, which then can cause bone mineral density issues. When you do have menstrual dysfunction, you should at least remember to look at a differential diagnosis. And if you ruled out other causes and there is a concern for weight, BMI, calorie restriction, then you may be looking at hypothalamic amenorrhea. So do a good history physical exam, look at your labs, your hormones, electrolytes, and things like that to help decide on what is the cause. In 2014, the Female Athlete Triad Coalition consensus statement on the treatment and return to play for the female athlete triad was presented at the 2014 AMSSM meeting. Again, they talked about the energy availability, that female athletes should aim for at least 45 kilocalories per kilogram of fat-free mass a day of energy intake to ensure adequate energy availability. Fat-free mass can be obtained from the measurement of body weight and from an estimate of percent body fat, and there are calculators on this website to help with those numbers. Again, treatment targets for these athletes is, of course, reverse the weight loss, return their body weight that's associated with a normal menses, and achieve a BMI greater than 18.5. If you are correcting these things in these athletes and increasing their calorie intake, it may only take days or weeks to recover their energy status, but it may take months to recover their menstrual status, and it could take years to improve their bone mineral density. In 2007, the ACSM talked about bone health to osteoporosis. We know that this is well defined in postmenopausal women. We use a DEXA scan to define this. Osteopenia in postmenopausal women is described as a T-score between -1 and -2.5. Osteoporosis is a T-score of less than -2.5. T-scores compare results with normal young healthy bone, and your Z-score compares the bone mineral density result to age and sex matched controls, and it's not used for treatment, but more to see if there's an accelerated osteoporosis. The T-score is not used in our adolescent populations because of the challenges of assessing bone mineral density. Instead, in this population, bone mass is defined as bone mineral density lower than expected for age-matched norms, and you also look at their fracture history. The ACSM defined in these premenopausal and adolescent patients that a low bone mineral density is a Z-score between -1 to -2 with secondary clinical risk factors for stress fracture. And those things can include chronic malnutrition, disordered eating, glucocorticoid exposure. They also considered osteoporosis to be a Z-score of less than or equal to -2, again with clinical risk for fracture. 50% of your peak bone mass is accrued during adolescence, mostly at the age of 11 to 14, and women achieve 92% of their total bone mineral content by 18 and 99% by 26 years of age. Exercise can cause an increase of 45% gain in bone accrual in prepubertal children. We know that oligomenorrhea and amenorrhea are detrimental to bone because they are hypoestrogenic states that inhibits osteoclastic activity and disrupts remodeling and accelerated bone resorption. Even if these athletes resume their menses, it may not completely improve their bone mineral density, but it can help to prevent fractures and hopefully osteoporosis. The prevalence of osteopenia ranges from 22 to 50% in female athletes, with osteoporosis ranging from 0 to 13%. This is compared respectively to 12% and 2.3% prevalence in the average population. In that 2014 Female Athlete Triad Coalition consensus, they also gave recommendations of when to order DEXA scans in athletes. If they have more than one of the following: a history of a DSM diagnosed eating disorder, a BMI less than 17.5, delayed menarche, prior stress fractures, and Z-scores of less than -2. If they have more than 2 of the following, you could order a DEXA scan, which is disordered eating, low BMI, again, delayed menarche, and again, the Z-scores that are low and those stress fracture history. Some of the other health consequences that can occur with the female athlete triad and REDS, not only are the menstrual dysfunction, but infertility. We know that this can lead to hypoestrogenism, which can lead to endothelial dysfunction and increased cardiovascular disease or elevated LDLs. It can affect your immune and your ability to heal from injury. Again, screening these athletes, we need to do our exams, look for abnormal behavior, do vitals, look at labs, and even a DEXA scan. Ask the questions about, do you worry about your weight? How many periods have you had in the past year? And have you ever had stress fractures? How do we prevent these things? Education, just like we're doing here tonight. We need to educate everyone involved with athletes that there is a health risk if you have low bone mineral density or menstrual dysfunction or several stress fractures. It's not okay. We need to make sure they have proper nutrition and training and that we're doing our proper screening. So step 1, evaluate the health status. Step 2, look at the risk factors, and then you decide, can your athlete compete? This is a worksheet that did, again, come from that Female Athlete Triad consensus statement. This can be helpful to some, where you mark the different risk factors that your athlete may have, add up your points, and then can they fully participate, have limited participation, or should they not compete at all? As far as treatment for female athlete triad or REDS, it is a multidisciplinary approach. You need your team physician, the psychologist, your dietitian, your coaches, athletic trainers, and parents. Everyone has to work together. You then again need to decide, is it safe for the athlete to continue training? Do we modify it, or should they stop? It is good to have a verbal or written commitment with that athlete that they need to be gaining 0.5 pound to 1 pound a week. Are they going to their appointments? If there is no improvement and they're not doing what they should, then we may need to remove them from activity. Just a quick review. For disordered eating, you definitely want to have your nutritionist on board to make sure that we have our daily energy needs to restore any body bone mineral density issues or menstrual dysfunction. You need your psychologist or psychiatrist to help these athletes with their unhealthy thoughts and behaviors. Sometimes it takes medications for that. As far as amenorrhea, rule out other causes, and then increase the calorie and correct the nutrition. In some athletes, if they are young and they continue to have bone density issues and stress fractures, you may want to look at birth control, but you can discuss that with your team. It is not first-line treatment. As far as bone mineral density, your athletes should be taking calcium and vitamin D. I don't just recommend high doses unless we have done labs. If they don't have stress fractures, weight bearing and resistive exercise programs are helpful. If an athlete is having stress fractures and their vitamin D is on the low end, even though it is normal, you really want those levels to be closer to 50 in an active athlete. We don't recommend bisphosphonates for premenopausal women because they can cause teratogenic effects. Just an update on REDS. Obviously, there are various different risk factors, numerous signs and symptoms, and even one's environment can influence if someone is considered to have this. The new 2023 International Olympic Committee on REDS came up with a clinical assessment tool version 2, and it has a 3-step process. 1 is initial screening. 2, they look at the severity and risk stratification based on signs and symptoms of this issue. And then again, a physician-led diagnosis and treatment plan that encompasses everyone who's part of that team. The clinical assessment tool uses a 4-level traffic light to decide if someone can compete or not compete. This quickly just shows a few of the risks that they're looking for. They call them severe primary indicators or secondary indicators. These are serious medical indicators. If someone's having EKG changes, orthostatic intolerance, then you can plug these into this green to red light and decide if your athlete should be competing or not, or how aggressive their treatment needs to be. On this clinical assessment tool version 2, it was developed using athletes testing and feedback, REDS experts, and physicians putting all their information together. How does this impact our practice and our future? Hopefully, this leads to a more accurate and early diagnosis of these issues and what is the risk of our athlete training and should they be training. Hopefully, this also ensures a more timely diagnosis and can prevent these issues so our athletes can have a healthy, active performance. Thank you.
Next up is one of our most recent members of the Andrews Sports Medicine, Dr. Matt Beidelman. He will present injuries to the young throwing shoulder and elbow. Matt is also a native of the Birmingham area, having graduated from Homewood High School. He received his medical degree from UAB and completed his family medicine residency at the University of Tennessee School of Medicine in Knoxville. Matt is a 2021 graduate of the ASMI Primary Care Sports Medicine Fellowship Program, and we're honored to have him on our staff. Take it away, Matt.
So thank you, Dr. Andrews, for that introduction. I'm Matt Beidelman. I'm going to be talking briefly about elbow and shoulder growth plate conditions and injuries in the youth thrower. And no disclosures. So first, I'm going to talk about the medial epicondyle apophysis. So this is a medial elbow. It is a spectrum of disease all the way from just inflammation and apophysitis all the way to avulsion fracture. The important thing to think about with these is that they're all really variations of a Salter-Harris 1 fracture, whether that is acute traumatic fracture or a more chronic stress of that growth plate. We'll start with apophysitis. So that is typically in adolescents and children ages 5 to 6, all the way up to 15 to 16 when those growth plates close. It is typically an insidious onset, so gradual onset of pain with throwing. When you talk to them, they don't really remember a particular throw or a particular game when it started. It just kind of gradually got worse over time, over a matter of weeks or even months. They can come in and say, well, I just couldn't throw as hard, or I couldn't control the ball, or my distance on my throws got worse and started having pain. It is very important to look at their shoulder. So look up the arm and make sure that their rotator cuff strength, their range of motion, both internal, external rotation are normal, because they may be dealing with some secondary issues in the shoulders actually causing them to put more stress on the elbow. So talking about medial stress, so the biggest risk factors for the development of medial elbow pain, whether that is apophysitis or avulsion fracture, have been found to be throwing greater than 80 pitches in a game, playing year round, not having any break to let the elbow and shoulder rest, The higher velocity is a higher risk factor for this type of injury, as well as throwing breaking pitches, particularly at a younger age. And then pitching despite arm pain, whether that be shoulder or elbow, is an increased risk factor for medial elbow pain and medial stress. So there's some particular kind of biomechanical reasons for young throwers to develop more stress at the medial elbow. They have a slower hip rotation, trunk rotation, decrease or slower external rotation, velocity of the shoulder. They also can have poor mechanics. They're younger throwers. They're still being coached up. And so their hand position on the ball, their foot placement on strike on the mound, and then their front shoulder. This image shows kind of the front shoulder being closed or open can vary the amount of stress on the medial elbow when they accelerate through the throw, and generally have less synchronization between the throwing arm and the body and the trunk. So imaging for apophysitis, we're going to be looking at 5 views of the elbow, but the biggest one we're looking at here is this AP view, just to look for widening of that growth plate. They may have adjacent sclerotic changes or cortical irregularity, and occasionally there's been fragmentation at that growth plate where it may not look like one single piece distally there. You could look at this in MRI. Typically, it's not required. It's more of a clinical diagnosis. But if you did, you would see edema within the flexor pronator mass, tendinopathy, edema within the humerus, and then see edema within the apophysis with some mild separation. So treatment. So the first thing is really discussing those risk factors that led to the condition, whether that be rest, the amount they're throwing, and the innings, and just the time of the year that it is and how long they've been throwing. From a treatment standpoint, the most important thing is rest from throwing. A minimum 4 weeks, usually 6 weeks. There is a recommendation that all adolescent throwers and young throwers have at least 3 months of contiguous rest from throwing in a calendar year. So it might, depending on where they are in the season, it might be worth going ahead and shutting them down to do that 3 months of rest. And then early PT, looking at rotator cuff strengthening, going up to the shoulder, making sure their range of motion is normal, making sure the rotator cuff is strong, then looking at the core and lower body to try to really get better synchronization throughout the body with throwing. Maybe worth looking, especially if they're concerned there may be a mechanical issue that's causing this, looking at biomechanical evaluation to address those while they're resting. And then when they are pain-free, they've done their rest, they've done their physical therapy, and all those corrections have been made, you want to do a gradual interval throwing program or ITP to allow them to progress the amount they're throwing, the distance they're throwing, and observe for any recurrent symptoms or pain. So then we're moving on to avulsion fracture of the medial epicondyle. So that's usually skews a little bit older. You know, that's not going to be you're really young, less than 9. We're looking 9 to 14, and they will remember a particular throw where they threw it, they felt a pop and had significant pain and swelling medially. They may also have some ulnar nerve type symptoms, numbness and tingling down to the 4th and 5th finger. It is important to obviously get x-rays of the injured elbow, but it can be very helpful to get contralateral films to compare, because we're dealing with a growth plate that's open and we want to compare the width of that growth plate and to determine abnormal displacement. There are a couple of other views that some of the literature has proposed to be able to more accurately grade or determine the displacement. So if you look on the right, you have your typical AP view. But and AP and lateral there, but then they've also recommended a internal oblique, which can better visualize the displacement, as well as a distal humerus axial view that might be able to more accurately tell you, is this significantly displaced or not, because that's going to really determine the treatment plan, as well as any significant instability there of the medial elbow at the UCL. So one question is this really something that always goes from apophysitis into avulsion? If we stop the apophysitis, are we ruling out these avulsions? There was a large retrospective study looking at this, and they found that a vast majority did have medial elbow pain prior to the acute injury. There has been a small case series that I also found that they said none had any pain prior to. But they also looked at those patients' compliance with the pitching guidelines, whether that be number of pitches in a game or the amount that they were pitching game to game. And all of those players were not compliant with the guidelines. So avulsion may not be 100% preceded by prior symptoms of apophysitis, but it is directly correlated to risk factors for apophysitis. So the treatment of avulsion, it's pretty clear cut when there is either minimal displacement or significant displacement. So if you're less than or equal to 2 millimeters, it's going to be non-surgical. Excuse me. You're going to do a very short amount of immobilization, usually about a week, followed by early motion, early physical therapy to normalize the range of motion of the elbow, prevent stiffness of the elbow, and then progressing into strengthening. Once the patient has good radiographic healing, normal strength of the shoulder and the elbow, and pain-free motion, then you can start that interval throwing program, usually at least 4 to 6 weeks out. So then we have on the other end, we have greater than 5 millimeters of displacement or significant incarcerated fragments or instability of the elbow, and that's always surgical to reduce the fracture. There is that middle ground between 2 to 5 millimeters of displacement that in the literature is somewhat controversial on whether to fix or not to fix. The mentors that I've trained under here at Andrews are a little bit more aggressive about fixing these surgically. And this picture, this image to the right is why. The true displacement of the fracture is not only seen well in the AP, there's also a rotational component, so that that fragment will shift forward and rotate anteriorly. And so the traditional radiographs can really underestimate the true anatomic displacement and ultimately lead to UCL issues down the road because they're now insufficient. So changing gears, we're looking at the shoulder now at the proximal humerus and a similar issue, something called proximal humeral epiphysiolysis, which is a Salter-Harris 1 stress fracture of the proximal humerus physis. And it's a little bit older. It's 11 to 16 years old, but most commonly in that center 13 to 14-year-old range. And it's thought to be caused by stress of the rotational stress at the late cocking phase, as well as somewhat to the distraction forces of ball release. One MRI study found that there were 2 very specific risk factors that had a significantly increased risk of this issue, and that would be year-round play of baseball and throwing, as well as playing the single sport of baseball. So, one way to potentially mitigate this is the rest, as we have discussed, but also playing multiple sports, being a well-rounded athlete. So imaging wise, you'll see on the x-ray that they have widening of the physis, metaphyseal sclerosis, fragmentation, cystic changes around the physis, best seen on that external rotation view. And also want to compare to the contralateral side to see that widening a little bit easier. On MRI, usually not required for initial diagnosis, but if those x-rays are not particularly impressive, you have a very high suspicion for this problem, or they're a little bit older, throw a little bit harder, and you're a little bit concerned that they may have more of a soft tissue injury, you might be getting an MRI to further evaluate this. At which time you would, on the T1 images, you would see widening of the physis with increased signal intensity, and then on T2, once again widening and increased signal. So treatment, once again, looking at the risk factors that led to the condition, a little bit stronger recommendation for at least 6 weeks of rest from throwing in the shoulder. They can hit and practice fielding if it's not painful. generally want to use that 6 weeks. They're halfway to their 3 months. So go ahead and start the 3 months of rest with the healing of this injury. Early physical therapy, once again, looking at the rotator cuff strength, looking for any internal rotation deficit to improve the posterior capsular looseness, core lower body strengthening. And then finally, once they are pain-free, they've completed their rest, their physical therapy, do that interval throwing program. So these are some images. In A, you have widening. B, that's the contralateral to compare. At 3 months, you've had some interval improvement in the widening of the physis. In 5 months, it's consistent with contralateral. So thinking about recurrence for this issue, it's up to 18.7% in a systematic review as far as recurrence from after typical treatment. The treatment plan for recurrence is really the same. You just need to rest for longer to get full healing. Consider resting from pitching the entire remainder of the season, even if they have good healing, just to try to prevent recurrence. On recurrence, it is, I think, very reasonable to look at a biomechanical evaluation. These are very common problems, but recurrence is not as common. So they may have a very simple mechanical issue to fix to prevent recurrence. So if we see in these x-rays, you have the initial presentation, A, B with the contralateral side to compare. At a month and a half, at 6 weeks of rest, it's functionally normal. At 3 months, remain normal. At 4 months, we have widening again. So they had a recurrence. They rested for longer, and at 9 months, they're back to normal. So the big takeaway points are to utilize the USA Baseball Pitch Smart guidelines that help determine the number of innings pitched, the number of pitches, how many days of rest in between to help prevent these issues with the shoulder and elbow. From a rehab standpoint and leading up to the season, and even within the season, it is really important to focus on maintaining rotator cuff strength, maintaining shoulder mobility, especially with internal rotation, to try to prevent and then rehabilitate these injuries when they happen. And probably the single biggest thing is if any athlete is having pain at the shoulder or the elbow, that they do not continue to throw, because that will ultimately lead to either issues at that joint or the joint adjacent. So these are my references, and that's all I have. Thank you.
Last but certainly not least, we'll hear from Dr. Jody Ortega. Jody received his medical degree from UAB, completed his internal medicine residency, Baptist Health System in Birmingham, and is a 2000 graduate of the ASMI Primary Care Sports Medicine Fellowship Program. So Jody's the dean of primary care at Andrews Sports Medicine. He initially worked in LA City, Alabama, before returning to Andrews Sports Medicine in 2002, and he assumes the directorship of the Primary Care Sports Medicine Fellowship Program in 2012. Jody's got a tough topic. He's going to talk to us about lumbar spondylitis. Jody, take it away.
Thank you, Dr. Andrews, and thank you for everyone for participating tonight. Okay, so we're going to talk about the non-surgical treatment of PAR stress fractures or lumbar spondylolysis. Again, I don't have any conflicts of interest. So objectives: review the definition and prevalence of spondylolysis, review the clinical presentation, diagnostic imaging options, including a classification system, and then review non-doctor treatment, including some different protocols that are published. So it's spondylolysis is a bony defect in the pars interarticularis, which is the posterior arch of the vertebral column. We're talking about stress or fatigue fractures, which are medically defined as isthmic type 2. There are some other type of pars defects that are congenital and developmental, but we're talking about a stress fracture in athletes. More commonly, it occurs on both sides as opposed to just one side. The vast majority, up to 95%, occur at L5, and then L4 is the next most common level, but it can occur at other levels as well. I've seen L2 and L3, but again, much less common. And this is the most common cause of low back pain in adolescent athletes. It's been reported that up to 50% of cases of back pain in adolescent athletes are due to spondylolysis. The prevalence in the general population has been reported as 4 to 6%, but in the athletic population, anywhere from 23 to 63%, and 8 to 14% of elite adolescent athletes. There are certain sports that have been reported at higher rates and higher risk. Gymnastics and cheerleading because of the tumbling backwards, the arching of the back, weightlifting, football, rowing, volleyball, and divers, but I've seen it in other sports as well, baseball, softball, really any athletic adolescent is at risk. And it's due to the mechanical factors related to repetitive flexion and extension, hyperextension and rotation of the lumbar spine that's involved in training and competition in these athletes. So the clinical presentation, in general, it's lower back pain, usually worse with activity, gets better with rest, can be exacerbated with extension or hyperextension of the lower lumbar spine. Occasionally it'll radiate into the buttock or posterior thigh, but not usually below the knee. It can be either a gradual insidious onset, or sometimes it's more acute. So they may have some mild symptoms and then they have a specific injury event that acutely worsens their pain. More often it's just a gradual onset that just continues to bother them as they're active. On physical exam, they may be hyperlordotic. They usually have tight hamstrings, usually pain with lumbar extension. Sometimes they're tender, either midline or paraspinous, but not always. And then the stork test is where you have them stand on one leg and flex the opposite hip and then extend their spine. And if it's painful, that's a positive stork test. You test each side, but studies have shown this really has a low specificity and sensitivity. And I found that clinically, lots of times these kids have a normal stork test, but then you image them and they end up having a stress fracture. And typically, if people have pain with forward flexion, that's usually considered disc pain. But I've had patients that they don't hurt on extension or only minimal pain on extension. They have more pain with flexion and they end up having a stress fracture. So you just have to have a high suspicion in these high school adolescent athletes. As far as imaging, usually we start with just plain radiographs. Usually APM lateral is sufficient. You can find it on oblique views. That's kind of fallen out of favor because that requires higher levels of radiation, which we're trying to avoid in these adolescent younger kids. Studies show low sensitivity on plain radiographs for picking this up. Obviously, if you see it, you see it, but just because you don't doesn't mean it's not there. Then there's single photon emission CT or SPECT scanning. This is more sensitive than plain X-rays and just a planar bone scan. So if you do a SPECT scan that is positive, this correlates with a painful or active lesion as opposed to a chronic inactive lesion. It's not specific, so if you do a SPECT scan that's positive, you need to follow up with a CT scan to further define the exact pathology, because it just kind of gives you a rough idea that there's something going on. It doesn't definitely tell you it's a stress fracture. It could be something else. So you definitely want to follow up with CT. The downside is there is levels of radiation. Again, with kids, we're trying to avoid that if possible. So then CT scanning, the pros of CT is studies have shown that the appearance of the fracture can correlate with the potential for bony healing. CT is best if you're trying to follow up longitudinally. Is there bony healing or not, and how's that going as you're treating them and following them up if you're going to do that. And a CT scan is quicker than an MRI, so if a kid has trouble laying still for a long time, a CT may be better just because they don't have to lay there as long to get the CT done. The cons of CT, it is less sensitive in distinguishing between an active and an inactive lesion because you're just seeing a bony defect or fracture, and doesn't tell you is that really the source of the pain. And it can miss early stress reactions or early fractures if you have a stress reaction where you don't have true bony defect or fracture line, you can miss that on CT. Sometimes you may see some sclerotic, what the radiologist will term as sclerotic healing changes going on, but you won't see a true fracture line. So you may miss something early with a CT scan. And again, probably one of the biggest negatives is the radiation exposure, as we've talked about. So usually if you're going to use SPECT and CT scan, you do the SPECT scan first. And if the SPECT scan is positive, and then you follow that up with a CT scan, but the CT is normal or negative, that would indicate what you have is a bony stress reaction with no fracture or defect. And that's actually a good prognosis because you've caught it early and you should be able to heal it and get bony union with appropriate treatment and rest. If you have a normal or negative SPECT scan, but a positive CT scan that shows a bony defect, that's indicating you just have a chronic non-union that's been there, and it's probably not the source of the pain because it's not what we term active. So in a study published in 2004 by Fuji et al., they described the staging of these lesions by using the CT. So if you have a narrow fissure or narrow defect in the pars, that would be an early or acute defect, early acute stage. If the margin's a little bit wider but not real wide, the margins are non-corticated, that would be termed a progressive defect. And then a terminal non-union, the defect's going to be wider and you're going to have corticated or sclerotic margins, indicating that it's a non-union, and you're never going to achieve bony union or bony healing in those terminal lesions. So now MRI has really become probably the most preferred advanced imaging. Some advocate that it should be the preferred, others don't. MRI, at least the older MRIs, the protocols, had a hard time actually delineating whether there's a true fracture or bony defect there. But some new protocols that have been developed, thin slice protocols and protocols designed to really evaluate the pars as opposed to the disc, have improved the sensitivity and the performance. So it's been reported as high as 92 to 98% with these new protocols. One study reported there's a high negative predictive value of 97% if you see marrow across the pars region on the MRI. Then another study showed a high positive predictive value, also 97%, if you see bony edema across the pars on the MRI. Again, MRI, because you'll pick up bony edema, so you can pick up stress reactions and early stress fractures that may be missed by your plain radiographs or CT scans. So really what you're looking for is you'll see cortical edema in the pedicle adjacent to the pars and maybe also along the pars area. And this is one of the earliest indicators of spondylolysis or stress injury. And when you see that, it can be a positive predictor of bony healing. So it's been reported that the ideal sequencing for MRI is to do STIR images. STIR stands for short tau inversion recovery. It's highly sensitive for bony edema. And so if you're seeing the bony edema, it's either an early lesion or maybe an older lesion, but it's active. It's probably the source of your pain. So that would correlate with a positive bone scan as well. And then if you're looking for the bony defect, things that are going to be more sensitive to the bony marrow, either T1 or T2 non-fat saturated images. You can see the cortical bone. You see high contrast between the marrow and the signal void of the disrupted cortex or the bony defect there in the pars. And you can actually, if you have the proper protocols and techniques, you can visualize the bony fracture on the MRI. You do want to do multiplanar, so axial, sagittal, and coronal oblique imaging. And if thin slices are best, at least 3 millimeters is the ideal sequencing. So the benefits of using MRI, it's a favorable side effect. Again, it's a magnet, so there's no radiation, so that's not a concern. You're going to be able to identify early bone stress injuries before you've got a true bony defect or bony fracture. A high positive predictive value. And the other main positive thing is you can assess other things at the same time. Do they have a herniated disc or degenerative disc? Do they have a nerve root compression? Is there tissue within the pars defect? Do they have foraminal stenosis that may be irritating the nerve root? Do they have facet joint arthritis or facet joint effusion? Other things such as discitis or infection, or hopefully not a tumor, but you can see stuff like that as well. So you can evaluate other potential sources of pain with one study with an MRI. The disadvantages of MRI, so more motion artifact can decrease your image quality. So if you have particularly a younger kid that can't lay still long enough, you may not get a high quality image there. It's really hard to grade or detect bony healing with MRI. So you have to use other modalities such as CT to do that. And as far as looking for a true bony defect, you have decreased sensitivity and specificity compared to the other imaging modalities. So it's been reported to be 59% for MRI compared to 77% for CT, a 41% false negative rate with MRIs as opposed to 23% for CT. However, there's new software that's being developed. One is called ultra short time to echo MRI, which has been reported to increase the sensitivity for picking up the true bony defect, in addition to the bony edema. And again, these new protocols have been reported to increase the sensitivity of MRI. But overall, again, opinions vary on what's the appropriate advanced imaging method to use. One study I read, they said MRI has no role at all in diagnosing spondylolysis. So there's some that don't believe in MRI. As far as non-surgical treatment, just the general principles, there's an initial period of rest to allow healing and decrease and eliminate their pain. Then there's going to be rehabilitation, and then moving back to return to play, getting them back to their sport. There's debate in the literature and through the studies of what's the best treatment protocol, what's the best duration of rest, do you use a brace or not? And if you do use a brace, what type of brace do you use? And then also duration and type of rehab, and also when to begin physical therapy and rehab. And then the timing to return to play, highly variable in what's reported in the literature. So here's one meta-analysis of non-operative treatment. 84% will have a successful outcome after 1 year. There's no benefit of bracing, and unilateral defects heal more often than bilateral defects. So 71% of unilateral defects when we talk about healing, I'm talking about bony healing, so like on a follow-up CT, not just clinical relief. And then 18% of bilateral defects will achieve bony union. And again, the early defects are more likely to heal. So if you have an acute lesion, almost 70% have been reported to achieve bony union. The middle moderate progressive lesions, almost 30%. If it's a chronic terminal non-union, again, that's a 0%, not going to heal. And then, so overall, the average is almost 30% of all takers that will get bony union. So this influences how we treat. So here's one treatment protocol reported by Tehima and McKelly. So the patient has symptomatic lumbar hyperextension. They do the AP and lateral X-ray, followed by the SPECT bone scan. If the SPECT scan is normal, they consider that there's some other source of pain, such as transitional vertebrae, maybe spinous process impingement, or it could even be disc or soft tissue. If they have diffuse uptake on the SPECT, then they treat them short-term with a brace as well as physical therapy. If it's a very focal area of uptake on the SPECT scan, then they'll do a CT scan. If there's no fracture seen on CT, which would indicate a stress reaction, again, short-term bracing and PT. If a fracture seen on the CT, then they use their brace protocol and physical therapy. So kind of getting into the details, once they diagnose it, they place patients in a Boston overlap brace for 23 hours a day. Basically, the 1 hour out is bathing. They begin PT with peripelvic flexibility, anti-lordotic strengthening. They can do their PT, stationary bike, or swim, with the exception of butterfly and breaststroke, as long as those activities are pain-free. At 4 to 6 weeks, if they have no pain with activity and no pain with lumbar extension, they allow them to return to their sport in the brace. And this is a rigid, almost plastic brace that they've placed them in. They keep doing their spinal stabilization exercises. If they're having persistent pain at that point, they start looking for other diagnosis that may be the source, continue to brace and PT until there's no pain if other diagnoses have been ruled out. So 4 months after their initial visit, initial diagnosis, they repeat a limited CT. If the fracture is healed on the CT or they have a pain-free non-union, then they let them start weaning from the brace. If they're still symptomatic and not healed, they'll consider using electrical bone stimulator with the brace to try and achieve bony union. So at 4 to 6 months, if they're still symptomatic and non-union, they offer bone stimulation as an adjunct to treatment. If they're 9 to 12 months and they still are symptomatic and have a bony non-union, then they'll consider surgery at L5 at in situ fusion and L4 direct fixation of the fracture. And this is a second treatment protocol by standard, ordered in 2002. Again, AP lateral X-ray, SPECT, bone scan. If it's normal or negative, again, consider some other source of their pain. If it's positive, then they do a limited CT at the positive level, and then they base their treatment based on the staging by the CT scan. So if it's an acute early defect, they'll rest them for 12 weeks. They'll consider bracing if they're still symptomatic after 2 to 4 weeks of rest. Then in their rehab phase, what they start at 12 weeks, they start range of motion, low impact conditioning, neutral spine stabilization. Then once they get through that recovery stage, continue range of motion conditioning, resistive strength training, continued spinal stabilization, assess everything in the kinetic chain and their sports technique. Don't want to begin that any earlier than week 16. So you're talking about 4 months out from diagnosis. If they're, for some reason they need to try and return earlier, they'll repeat the CT scan at 12 weeks and let them advance if it shows healing of the fracture or the bony defect on the CT. And they'll progress to their functional stage where they're continuing conditioning, strength training, dynamic, sport-specific training, and get them back into their sport and make sure their technique is where it needs to be. So they're in this protocol, they're getting back to play somewhere 5 to 7 months. They have to go through all those stages of rehab, have full pain-free range of motion, normal strength, good fitness, etc. If it's a terminal chronic defect that's going to have no chance of bony union, they rest them until they have pain-free range of motion. Again, put them in a brace if they're still having pain at 2 to 4 weeks. Once they become pain-free, they'll begin their rehab and let them progress through each phase, as noted earlier in the other protocol. And then they're returning to play somewhere 2 to 5 months based on their being pain-free. And if they're not symptomatic, they don't have any routine radiographic follow-up. Again, it's a terminal defect. You're not going to get bony union, so there's really no need to do that. So here's, I call it the ASMI or my protocol. Dr. Ray, who was also formerly here, we kind of treated this the same. So this is my former protocol. Again, AP lateral X-ray followed by SPECT scan. If the SPECT scan was positive, we did a CT scan. If the CT showed it was acute or progressive, the early to mid lesion would rest them from 3 months at least from their athletic activity, put them in a lumbar corset brace if they were still having pain after 2 to 4 weeks of rest. After 6 weeks of rest, we would begin physical therapy with an anti-lordotic flexion-based rehab, let them walk or ride stationary bike if they were pain-free. And if they were doing well at 3 months, we'd let them begin returning to play, getting back to their sport. When I was doing this protocol, there were a few patients that took longer. You'd sometimes 4 to 6 months before they became pain-free and could start working back in the sport. If the CT showed a chronic non-union defect, like just the previous protocol, just rest them until they become pain-free, let them go ahead and begin physical therapy when they're ready. And then once they're pain-free and kind of just progress back to full activity, as fast as they can go, because you're not trying to get bony union, you're just trying to get them to be pain-free and be able to return pain-free. And then I found early on in my career that once some of these kids went back, particularly the football players, a lot of them would come back with recurrent pain sometime, months later after they were doing squats and power cleans. So I've started doing a permanent restriction of don't do back squats with a bar on your back, don't do power cleans. And we came up with some other exercises working with our physical therapist. They could do wall squats, just body squats, goblet squats, RDLs, single leg RDLs, things like that that weren't going to load their lower back, but still let them have appropriate strengthening. So here's my current protocol, changing to using MRI. I started doing this after attending the sports medicine conference at the Southeastern ACSM in 2015. There were some pediatric sports medicine doctors there from Vanderbilt, and this is what they reported that they were doing. So they start with a lumbar spine MRI with STIR, and the basis behind this is you're trying to avoid the radiation of the SPECT scan and the CT scan. We know the majority of these lesions are not going to achieve bony union, so that should not be our goal. Our goal should be to get them to be pain-free, return to their sport. The studies show that if you treat them appropriately, 85, 90% or more of these kids are going to be okay and get back. So there's no need to do CTs and stage all these things. It was really do an MRI, see if there's bony edema or an active bony defect with edema around it that would suggest that's the source of their pain. It's an active lesion. So start with the lumbar spine MRI. STIR is important because that's higher sensitive for picking up the bony edema. If the MRI is positive, start rest right away. Again, let them walk or ride a stationary bike if they're pain-free. Go ahead and begin physical therapy right away, again, with anti-lordotic flexion-based rehab. Again, if they're still painful after 2 to 4 weeks of rest, consider putting them in a lumbar corset. Either dispensed from our office or something over the counter would be fine. And then return to play. And they stated, when I talked to them in 2015, they're like, we recheck them at 6 weeks, and if they're pain-free, let them start working back in the sport. And what I've found since I've been doing this is if they may be pain-free at the 6 week point, but if they haven't been pain-free for 4 to 6 weeks, they're going to have recurrent pain. So they come back at 6 weeks and they tell you, yeah, I've only been pain-free for a week or two. If you start sending them back to their activity, they're going to start hurting again. So my criteria is they have to be completely pain-free 100% of the time, 24/7 for at least 4 weeks, preferably 6 weeks. So at least 4 to 6 weeks, completely pain-free, and then you can start working back into the sport. And I found that most of the time, the vast majority of the time, keeps them from coming back right away with recurrent pain. And again, I give them the same permanent restrictions as before. So as far as long-term outcomes, there's one reported study by Sousa et al. Published in 2017. They had 61 patients. They had to have at least a minimum follow-up of 2 years out from diagnosis. The average age of diagnosis was 14, with a range from 8 to 18. Their mean follow-up was 8 years, range of 5 to 14 years of follow-up. And the title of their study was Midterm Outcomes, but I'm calling this long-term, and you'll see here in a minute why. So mean follow-up of 8 years, 55 of 61, so 90% returned to the sport, 70% returned to play at the same or higher level, 78% reported pain at 3 or less on a scale of 0 to 10. 58% reported no pain at all. Their average pain was 1.25 among all patients, with a range of 0 to 8. So ASMI study, we just completed a study here at ASMI. We started this 4 or 5 years ago and finally finished it within the last year. So we had 150 patients that had a minimum of 5 years follow-up. So my criteria was they had to be at least 5 years out from diagnosis before they would be included. Average age at diagnosis was 16, range of 11 to 24. 16 is kind of in line with all other studies that you look at with spondylolysis as far as the average age at diagnosis. Our mean follow-up time was also 8 years, so similar to the study I just talked about. We used the Westry Disability Index, which is the gold standard for reporting outcomes in low back pain and lumbar pain studies. So the mean score was 3.6 with a range of 0 to 32. So 0 is the best, and 100 is the scale from 0 to 100. 0 is the best, 100 is the worst. So very low pain scores, very good outcomes. 3.6 was the mean score. And we had 91% of the patients reported returning to play at the same or higher level, so a little bit higher number than the previous study. And then in ours, if it was a female, if they were younger at the time of diagnosis, if they had a longer follow-up time, that was associated with having a worse ODI score at follow-up. And we just finished that within the last year. We haven't published it, but we're planning on doing that. So in summary, the non-surgical treatment, again, there's a lot of differences in treatment protocols reported. There's been no published controlled trials comparing the different protocols, so it's really difficult to define what the optimal treatment algorithm or recommendation is. You can see that as good or bad. I think the good thing is you can treat this lots of different ways, and most of these kids are going to be fine in the long run, short term and long term. Again, the vast majority do well with conservative care and can return to play with minimal to no symptoms. And again, the vast majority of these bony fractures do not achieve bony union, although clinically they're going to do well. 85 to 90% plus are going to be fine. There's my bibliography. Thank you. I think now we have questions.
Question while we're waiting to see if there are any other questions. Sounds like you really got something there with the conservative treatment, and you really studied it. You certainly need to get your latest study published. But what do you do? Is there ever any indication for any kind of surgical treatment? Because it sounds like about 10% of them, or 10 to 15%, continue to have trouble. What do you do with those? Do you just let them go on, or is there any surgical treatment for this?
There is. There's different, I'm not a surgeon, obviously, but there's different surgical techniques that have been reported. I personally have not had a patient that had continued pain that needed surgery. I know one of my partners in our practice had a patient that had pain for over a year. So I think it's going to be a chronic thing. They're going to have pain for a year or longer, not responding to rest and therapy, and they just can't do their activity that they want to do before you're going to consider surgery. In our study, there were 5 patients that had surgery at some point down the road. We haven't dug into the details yet of how far out they were from diagnosis or what surgeries they had, but there were 5 in our study that reported having some type of back surgery somewhere down the road. So there are some that do need it. It doesn't happen very often. But again, it's going to be something that's going to be chronic. You're not going to want to do surgery at 3 months or 6 months. It's probably going to be at least a year out or longer.
You said that women did maybe worse than men. I think is what you said. But what sport is the real culprit, or is it just weightlifting?
I think it's any sport, particularly these days. I mean, classically, it's been the hyperextension sports such as gymnastics and cheerleading, weightlifting, football, particularly linemen, because when they hit, they'd arch their back. But really, in my experience, it's any sport, particularly these days, because these kids are starting to lift weights at an earlier age than back in my day. They're playing one sport all the time, so they're doing the same motion all the time. As opposed to those, again, goes to some of the baseball injuries. If they play multiple sports, you're having different motions and stressing different things. So really, to me, any teenage kid, particularly playing sports, that comes in with low back pain, that's the first thing on my radar is, do they have a stress fracture?
Well, for years, we have finally realized that it's okay for pre-adolescent kids to do weightlifting. And when we say weightlifting, we're talking about multiple reps and lower weight. We're not talking about maxing out. And I would imagine what's happening now with strength and conditioning being so popular is they actually have these kids deadlifting maximum. And the weightlifting is beyond what we normally consider to be safe weightlifting for a young kid. Is that what you're seeing?
Yeah, I'd say so. They're lifting too heavy, doing too few reps. They need to be higher repetitions.
Like everything else in youth sports.
Right. And then, school coaches are variable in their knowledge. They're using proper technique. Are they being supervised properly? Those kinds of things. So it all plays into the risk factors.
Here's a controversial question.
Yes.
You talked about stress fractures of the tibia, the dreaded black line. And if you see that, we're pretty quick to operate on it. But the controversy now amongst the people that really see that problem surgically is whether they do a intramedullary rod or whether they do a plate. I don't know the answer to that, but what do you have any idea what's the going situation at Andrea Sports Medicine relative? Anybody putting plates on it?
I don't think they're doing plates yet. They're still doing intermediate rods down the tibia. I've had maybe 4 or 5 in my time here at Andrews in Birmingham that we've seen a dreaded back line, which is never good news to deliver to the patient. But Dr. Waldrop, Dr. Keene, and Dr. Dugas and Dr. Emblem are still doing intermediate rods, as far as I know, for tibial stress fractures that have a dreaded black line or people that don't improve with conservative treatment, 6 or 8 weeks of boot mobilization or non-weight bearing status.
Well, just for your information, be on the lookout because using plates is beginning to have some traction. Let me ask, let's see here. Where's Matt? I was interested, you taught me something. I just had a kid the other day, 16-year-old baseball player playing year-round baseball, multiple leagues at the same time, no rest. Pitcher, grew up fast. He's 6'3" and he's throwing 93 miles per hour, and he's still got open growth plates. And you taught me something about the oblique internal rotation oblique view. Does that show it up better? I think I know why, but I mean, why is that a better view?
So I think it better shows the kind of anterior translation as opposed to the AP where you're mostly seeing medial to lateral displacement. You're seeing a little bit more of that rotational change.
I think you're right, but I didn't know about taking that view. Here's the problem. The way that displaces, when you get just a straight AP, you're looking at displacement between the widening of the line, but you don't see the displacement that where the fragment goes anterior, and the muscle pull on that fragment when it's pulled off pulls it anterior. And if you look at your lateral X-ray, you get the right view. Sometimes you'll see that it's the front of that fragment is way in protruding in front of the anterior aspect of the humerus. And a regular AP X-ray, they think it's non-displaced, but it displaces anteriorly. And I guess that internal oblique view brings that out, and therefore it's probably mandatory now that you do that view when you have this particular problem. And of course, you also, as you said, you need to X-ray the other elbow and compare. But I can see that view will help you with that anterior displacement. It looked completely normal on AP, and they'll say you don't need to operate on it. Yet it's sticking up anteriorly 4 or 5 millimeters. How are you doing with controlling the throwing situation in youth sports through Andrews Sports Medicine? Are y'all seeing an increased number of injuries?
I think I am, especially this time of year when you're getting kind of towards the end of All-Stars. They've been throwing for 6 months and they're probably overthrowing and throwing through soreness. And then it's kind of sometimes their most crucial part of the year where they're doing these showcases and travel ball and really telling them that
it's a mess, isn't it? I used to think this was a coach's problem, but the more I deal with it, the more I've determined that in my own mind that the parents are the real culprit. They're the root cause. And it's been increasing since year 2000 in our statistics at ASMI, and it's going up still. So keep your eye on that and help with trying to figure out how do we prevent injuries in these sports.
We have a couple questions from the audience here.
Go ahead.
So one question for Dr. Ortega. Any indication for steroids in the acute phase of a spondy? What if radiculopathy is present initially?
So I'll have to admit, anti-steroids for almost everything to begin with. I think part of it is being internal medicine trained. Our program director was an endocrinologist, and he pounded in our head the adverse effects of steroids because that's what he saw in his practice. So in my opinion, um, I don't prescribe steroids acutely. If you've got a bony stress reaction and not a true fracture, if you're trying to achieve bony union, steroids, we know that steroids inhibit bone healing. So why would you put somebody on steroids, even acutely? So, I mean, I guess if you did a CT or some imaging, you knew that it was a chronic non-union and you're just trying to relieve their pain, then you could put them on steroids. Um, Again, in my opinion, I'd try other things first if possible. Now, they have radiculopathy. I mean, you're thinking maybe this is a disc and not a stress fracture. Maybe it's disc herniation, disc bulge with some nerve root irritation or compression. Um, and if that's the case, I may still get an MRI because you'll pick that up as well. And they may not have a stress fracture; they got a disc problem. Or I just put them on oral NSAIDs maybe to start with and check them back in a couple of weeks and see whether they're getting better. So the presence of radiculopathy wouldn't really change my approach to steroids. I know a lot of people do prescribe Medrol dose packs and oral steroids, but that's kind of my personal bias and feeling on that.
Emily, are you still there with us?
Yes, yes.
Help me a little bit. Unbelievable subject that you had. I'm always interested in hearing about it because it's difficult as a male orthopedic surgeon or male primary care, whatever, to understand all this. But tell me the relationship when you've got relative energy deficiency in sports. What does it do? You mentioned it a little bit. What's the reaction and how does it affect the osteoblastic versus the osteoclastic activity? Which one's affected and how?
So, definitely in these athletes, if they're overtraining, not getting enough calories or energy intake, and they're in females decreasing the energy needed to continue normal body function, and then they have low estrogen states, the body doesn't absorb vitamin D as well, then you definitely are preventing bone rebuilding, and then you can increase bone degradation. So it kind of affects a little bit of everything in the knowledge that I have with that. So it's just a constant battle between the two because they don't have enough energy to continue those normal body functions as they need to.
It's a mess, isn't it?
Yes.
What about the mental aspects of this problem?
So the mental aspects for sure. Again, I mentioned like the military. Well, they have their own type of stressors for certain reasons because they're protecting, their state or their country. Then you have athletes who have pressures from coaches, just pressures they put on themselves because a lot of them are, striving to be the best and doing whatever it takes to get there. So it can be very stressful. And then you kind of lose sight of, okay, I need to have rest. I need to have good energy. I need to take in the right nutrition. They lose sight of that with these type of problems. And it can be a lifelong battle.
So there's an increased suicide rate with it, right?
When I looked at some of my articles, it didn't completely talk about suicide, but I definitely would think that is an issue since depression and anxiety, is again prevalent in our society and prevalent in these high profile athletes who are either in high school trying to become college athletes or college trying to become professional athletes. So I do think that is a concern.
All right. We have any other questions from the floor?
Looks like there's a question here for Dr. Casey
Yeah.
regarding, do we see more reds in skeletal immature athletes, or is the prevalence similar across adolescents aside from vanity sports?
I don't necessarily think see it more in skeletally immature athletes. Probably adolescent, high school. It can happen, and again, for some of these, maybe the skeletally immature athletes, is it because of stressors at home? They are getting a lot of pressure to be the best in their sport because maybe their family does depend on these type of things for their future. So I don't think you necessarily see it more in skeletally immature athletes.
One more question from the audience. Dr. Casey, what are your thoughts on putting a female collegiate D1 soccer player on birth control to help reduce injuries, specifically ACL tears?
So it has always been my understanding through my knowledge and training, and if my partners want to jump in, I have never been one to jump to birth control as a treatment to prevent injury or to increase bone density. I think we need to increase your energy intake, your calories. I think there are great programs out there to prevent ACL injuries, to strengthen your hips and your core and land properly. So I definitely would start with those things first before I looked at a medication or birth control to prevent those things.
Emily, one of the
Yes.
things that I picked up, maybe y'all, I don't know if everybody caught it, but you talked about it. And I was trying to figure out, what is she talking about when you said surprise pregnancy? And I assume that means the ovulation is so off, it's not consistent. And
Right. Yes, you can
is that
have.
what you meant?
Yes, you can have, amenorrhea and infertility, but then if you start having these type of energy issues that affect normal body function, you could have changes in your cycle, and yes, ovulating at different times, and you could have a surprise pregnancy. But the other thing I was talking about is just when you're trying to figure out what's causing the menstrual dysfunctions, don't forget in your female athletes at certain ages to ask those questions.
All right, I think with that, we'll close it up. Anybody else have anything, any burning statement or questions? And otherwise, I think we've had a great podcast, and we'll call it quits. Any other questions? Thank y'all very much. It was really good. I enjoyed listening to it. Thank y'all very much.
Thank you.
Thank
Thank
you
you.
all.